computer.
Morning, morning, Ollie. How are you?
Hey, hey, here we are again, Tim. Nice to see you.
This is getting a regular thing. It's good. I think I think it's going to be good. I think as we go, I think we get better at this kind of stuff. I think it'll be good.
Yeah,
But
yeah, it's
big
nice.
news, big news this week. There's been
Big
two things, hasn't
news.
there? There's been the kind of the announcement of the kind of the benefits and the kind of the government kind of U-turn and things, and of course then there's been the 10-year plan, which was just yesterday, released yesterday. So
Yes,
it'd
big,
be
big news. We've been waiting, certainly been waiting with bated breath for 10-year plan, haven't we? But I think the welfare vote and the big climb down on that was really interesting, wasn't it?
Yeah, so say a bit more in terms of because I know you've already written a kind of a post on LinkedIn about it, and thinking a little bit about kind of what that means for people and whether it's the right approach. So say a bit more about that.
Yeah, well, it really made me think actually. The sort of, obviously there's a massive concern, isn't it, that the nation's welfare bill is skyrocketing, and a big part of that is being people being off with ill health, and we sort of know that's hitting both extremes. It's like young people who are not getting into work at all, not starting work, so coming out of school or college, and just not starting work, going straight on to benefits. And a lot of that is around mental health, sort of lack of confidence associated with sort of an increased awareness of neurodiversity. And, you know, we're not serving those people very well. The other end of the scale, there's people that are sort of over 50. Goodness, what a terrible age to be, eh? Where people are experiencing more chronic pain, and in particular, back pain, neck pain are the most common, and consequently being feeling unable to work because of those conditions. Now we could come back to the mental health, but the chronic pain is one of our big areas, Tim, isn't it? We started in chronic pain, didn't we?
Starting chronic pain, and again, I think our thinking about kind of chronic pain has moved on with the pain science.
Absolutely.
And we now understand kind of chronic pain being a result of an overprotective brain and that kind of that fear which kind of drives the pain. So yeah, I suppose, and I know you've commented a little bit on this, so maybe say a little bit about what you think maybe the government's maybe not getting quite right.
Yeah, I mean, it's so hard, isn't it? Who would want to be in government or a politician? It's almost like a no-win situation, isn't it? Everything's more expensive. We need money for everything, but at the same time, we just haven't got any money. Do you know what I mean? We're the country's broke, really, aren't we? So they're desperately looking to find places they can reduce spending, and I guess looking at areas that are ballooning, you've got to almost desperately do something to stop it, haven't you? But like you say, the neuroscience of chronic pain has really changed, or our understanding has evolved. And we used to think the brain made pain as a result of tissue damage and as a marker of ill health. That's what we've all got used to. But what we've learned over the last sort of couple of decades, but particularly the last decade, really, isn't it, is that the brain is a predictive, incredible predictive sort of machine computer sort of it's the most incredible thing, but what it's essentially doing is it's trying to predict things to keep us safe and conserve our energy and keep us alive, and one of the levers it has to do that is to give us pain signals. So the brain is giving us pain when it thinks we need protecting, and sometimes that's because we've had an injury and it needs us to sort of like, stop moving so things can heal. But what we know with chronic or persistent pain, which makes up a huge amount of people on welfare these days, is that what often happens is the brain gets stuck in overprotective mode. So it gets stuck in this mode of thinking it needs to protect you, but actually there isn't any tissue damage. The tissues have healed, inflammation has settled, the irritation has settled down, but you get left with an ongoing experience of pain. And of course, as a result of that, you stop moving, you get deconditioned, you stiffen up, you lose your confidence. So there are sort of emotional and physical consequences of that. But at its core, it's this brain being stuck in protection mode. So and what we know about that now is that the worst thing to do to an overprotective brain is to introduce more threat. And we've learned that with the deprescribing. So we kind of know that opiates and strong painkillers aren't really useful when you're dealing with an overprotective brain situation. They're very useful, if you've got tissue damage, so you've just had surgery, you've had a major injury, then painkillers are great. They help us to kind of cope. But once you've got past that stage and actually what's happening is the brain's stuck in overprotection, painkillers don't help at all. But if you swing in and go, right, we've heard painkillers don't work anymore, we're going to stop them now because they're probably not doing very much to you, and you don't do that in a clever and thoughtful way with the patient, their threat level flares up and actually their pain gets worse. So we've learned from that you have to be very careful and gentle and supportive around how you get people off medications, which is very useful because you reduce side effects, and actually sometimes these medications are making the pain worse as well. So we've learned from that. But I saw parallels with what's happening with the benefits, really, because of course, if you swing in and go, look, you really we can't afford to pay you the welfare bill, we're going to have to kind of cut back, and people perceive that their income, which is not high anyway, welfare benefits is not huge anyway, and you perceive that's going to be shrunk even more, of course, you're going to massively flare up in a threat mode. And probably that's not great if you're struggling with your mental health, but it's also definitely not great if your main problem is chronic pain, musculoskeletal pain, which is the mainstay of what's keeping people off work in the older ages. So it just made me think, and I'm sort of waffling on a bit, but it did make me think that now that we are more aware of much more supportive ways for people living with chronic pain. We're almost on this cusp, aren't we? This is something that you and I have been really keen on, and where we've been supporting the direction of health coaching. It is a coaching approach to pain management, where you teach people about what's going on in their brain, where you help them to gradually build their confidence up with good support, but appropriate challenge and some really clever techniques now. There's some really good techniques for rewiring your brain and helping your brain to feel safe again and start to move. Not in a bullying way or a stick way, but in a sort of like a really inspiring and life enhancing way. And you and I have both seen so many people now, haven't we, that have rediscovered the pleasure of being able to do things again, regaining life, literally regaining their life. And I just feel like we can do that now, and we should be doing that. And that would be a much better solution, I think, to the welfare problem we're seeing, certainly at the older end of the scale. Don't know. What do you think, Tim?
Yeah, I love that parallel, and I remember because it comes up on our kind of it does come up on our kind of pain courses a bit. People setting up these deprescribing clinics. I'm thinking, who's going to want to kind of sign up to a deprescribing clinic where someone's going to be taken away from you? There may be a few people where that might be helpful, but I think there'll be a few. But then there'll be a whole lot of the people where they'll be like, well, I'm not going to go to that. Why would I get involved in that? And I think what we often say is that, people reduce their medication almost as a side effect of good pain management.
Yeah,
That happens. So you're absolutely, yeah, I think you might be onto something that actually if we are able to provide an environment where people feel safe and people feel supported, then actually and feel like they can see the value of returning to work for themselves and um, for the people that they look after, then that's got to be a better way. And they'll almost withdraw themselves from benefits because that's no one wants to be on benefits.
yeah,
Like you say, it's a small amount of money,
yeah.
and no one is well off on benefits.
No, it's
And
very
people,
restrictive, isn't it?
yeah, I
It's very
agree.
restrictive. It's restrictive to you financially because it's kind of just hitting the bare minimum, really. But I think it's also restricted to you quite emotionally and from a self-esteem point of view as well. But we know people need a sense of coherence in life, don't they? Life works. I remember Aaron Antonovsky's Salutogenesis work, and the main thing that came out from his work, the biggest kind of predictor of whether or not you feel happy and you feel fulfilled with your life, is this kind of sense of meaning. Does your life have a sense of coherence? And so much of that is around what you're able to contribute and what you're giving back and what your role is. So, if you are on benefits and you're feeling that sort of, over 50, on the shelf, what use am I to anybody? I can't do anything. It's really not a nice place to be. So people don't, sort of go, great, and I'll just get there and I'll just be on the welfare kind of, ticket for the rest of my life. But what's so frustrating, isn't it, is that we now know we can do this so much better, don't we, in the field of chronic pain? And I'm seeing a lot of the health coaches that we train and a lot of the people that come on our pain course, talk to us about the difference it makes to how they then interact with people. We've seen the work that Pure physiotherapy have been doing, haven't they? Setting up a whole team of health coaches that are really good coaches, but then have really good pain self-management skills. And they've been improving people's pain, improving their function. As you say, they come off medicines not because they're being actively necessarily de-prescribed, although there's a technique to that, isn't there? But
Mm.
because they don't need them anymore. And there's a
It,
massive benefit to that. Like I say, NICE says, these painkillers don't help you. In fact, if anything, they often aggravate your pain system. Opiates can make that overprotective brain more sensitive. So there's a really logical reason, rational reason to come off them. But if you don't do that in the right way, you flare up that threat system and you make it work worse.
mm.
So it's a little frustrating that I think we've come through. Maybe we're at the cutting edge, Tim, and it hasn't got through to some of the government policymakers. But I think we could do so much better with this than just sort of a more blunt, we're bust. We've got to reduce the budget. Let's just pull back.
Yeah, and you can see where I mean you can see the need to do that, but you can also and you can see some of the maybe the logic of people thinking, well, that's the way to do it. But I think we know that that is probably not the well, it's not the probably the best way, certainly not the maybe the kindest way to go about this kind of work, but probably not the best way, I think,
No,
ultimately.
and
I
you
was
can.
reminded as you were talking there, my my wife Alice said, purposeful activity promotes health and well-being. And we know that. So we know it's good for people, isn't it, to have
Well,
some
Ali was an
purposeful
O.
activity.
She was an OT, wasn't she? So she would know, eh?
Exactly. Yeah.
Occupational therapist getting people back to work.
Yeah, exactly. And really important. And I go, we're working with people, aren't we? With the work well schemes, to support people, staying in work and getting back to work. And I think that's really important as well.
Yeah, that's a really interesting project, actually, isn't it? Lovely to see that in some quarters people are sort of realizing that if the barriers to work are mental ill health, chronic pain, actually what we need is of course you need people to find good quality work and to help to tailor the work to suit people, but also that sort of health coaching style approach that helps to build people's confidence and build people's coping skills, being aware of the latest science and some of the latest principles behind chronic pain, mental health, metabolic health. I think all these things have evolved so much in the last few years that we've got a lot more to offer people. That is it kind of threat de-escalating. Do you know what I mean? And confidence building. And I think those for me are the two really key things to have on the table.
So I suppose just to kind of round off this a little bit, because I'd love to get onto the kind of the 10-year plan. But so if they said, Ollie, look, here's the money, Ollie, what would you do with it?
I don't think it needs to be hugely expensive, does it? But I think it's moving towards a rehabilitation style approach. I think really, there's something about selling a new type of narrative, isn't there? We can support you back to work, and I do hear some of that. I definitely do hear the investment plan for, sort of helping people on a pathway back to work. I really do hear that, but I think the threat of reducing people's benefits hanging over that will undermine that. So it's really tricky, isn't it? Because clearly we need something quickly, because we are just literally running out of money, aren't we? I mean, the thing is, I don't think this does take a long time. I think if we've set up really good pain rehabilitation services for everybody, but particularly with a focus around people who wanted to get back to work, struggling to stay in work, then I think we would have a massive impact. So it wouldn't take a huge amount of investment, I think, to make a massive difference.
Yeah, nice one, nice one. Nice to finish on a positive note on that one as
Yeah,
well. So
yeah.
what anything more to say about that, just to check
Well,
before
no,
we
but it links to the 10-year plan, I think,
yeah.
because which is I think you wanted to move on to, didn't you?
Yeah, well, I was going to check, but I don't want to move on unless you're finished.
No, I think it's related really because I think in terms of things like chronic pain, which is an area that we do know well. At the moment, there just isn't any sort of incentive. There's no one's commissioning the type of care we're talking about. So we're talking about sort of a big holistic package of support, which includes people's physical assessment, making sure they haven't got any red flags or anything that we're missing that's causing their pain. So they need a good medical assessment, but then they need really good coaching style rehabilitation. alongside probably, social prescribing if their kind of current social situation is difficult, and that sort of back to work employment support, community development to help build people's confidence, and perhaps when they're in work, helping them to sort of cope with that through the social network they're part of. So it's quite a complicated picture. And what I've seen as a PCN clinical director is that we've had the opportunity to bring in some new roles to expand this rehabilitation MDT. So we've been able to bring in social prescribers and health coaches and care coordinators, occupational therapists. So we've been able to experiment with these new roles, but where it's really fallen down is we don't really have a contract to treat people in that way. We can put the roles in place, but no one's incentivizing us to sort of take people on that journey. And in fact, the current system disincentivizes it. The contracts for GPs are really around, getting through the demand, that 8 o'clock rush they always talk about. So if you fill yourself up with complicated patients that take a lot of time, you're going to lose all your appointments. So you're trying to bash them off in a way, really. We're hitting QOF targets, so payment by performance for specific disease areas, get people's blood pressure down, get their sugar levels down. It's very blunt disease specific areas, again, which doesn't really incentivize you to take a holistic, all joined up approach to somebody. And GP practice managers, GPs as a business, they're very good at delivering to what they're being commissioned to do, what they're paid to do. Practice managers are excellent at hitting all those targets because they're very good at performing to what they're asked to do. So we're lacking that in primary care, and the hospitals are the same. Hospitals are incentivized with episodes of care, to pay people for the more medicalized, the more complex, the more invasive it is, the more money they make. So again, they don't like this really messy, complicated, perhaps slightly drawn out. Maybe it takes a few months, 6 months to really take someone on a journey. No one in the system is incentivized to do that, to deliver that sort of care at the moment.
Yeah. So you talked a little bit, I think, didn't you, about the kind of the year of care kind of funding model. So do you want to say a little bit more about that?
Yeah, so that's the thing that I saw. You see this 10-year plan come out, don't you? And there's loads in it, and everyone's probably thumbing through looking for something. Oh, that's good for me. That's good for me. Oh, I don't like that. But the bit that really jumped out for me was this concept of year of care as a funding model. So the idea, as I understand it, behind this is that you look at kind of the total spend on somebody. Let's say someone living with chronic pain. So you've got how much medication they're being prescribed, how much that's costing, how often they're seeing the GP, how often they're turning up at A&E, how often they are having sort of mental health input or therapy, or and then perhaps how much they're costing in terms of benefits and how much their sort of social support network is costing. So I would love to see us, if you like, bundling that all together and offering that as a contract, saying to a system. So they're talking about these new sort of neighborhood teams, aren't they? Saying,
Mm.
okay, for this group of patients like that, this is how much it's costing us at the moment. When we bundle it all together, it's usually a huge amount. Actually, if you took a multidisciplinary, multi-professional approach to it, focused around the person, built around what they really want and what matters to them, how would you work with them differently? And there's really strong evidence that if we did that, that we could massively reduce the costs. People wouldn't be bouncing around all over the place, going into accident emergency, having emergency sort of interventions, much more controlled. And for me, the key of a year of care sort of approach, if you like, really, is that it is around it's enabling care. You're supporting people to feel good about themselves, to be able to do whatever they can, whether that's looking after themselves or work or even contributing with peer support and joining in. You're looking to enable people so they feel good about themselves. And on the back of that, we know, wellness improves and the spend of the system on them decreases.
Yeah. Yeah. I listened to a podcast recently. They had someone from the National Association of Primary Care, I think the head of the National Association of Primary Care, and they said for every £1 you spend in the community, you save £14 to the
Yeah,
system.
yeah,
But they said you've got to spend the £1. You can't just,
yeah, yeah.
so we've got to do that. So that's yeah, that looks like a really good model.
Yeah, so I mean that's It came out of pilot work up in Newcastle, didn't it? The Year of Care team there, and so they've got quite a lot of sort of process around it. But the heart of it is that sort of preparing people well, helping them to understand what's available, and really focusing on what matters most to them. What is it that they want to get out of life, and then you can start to shape things around that. But you're reducing threat, you're reducing people's panic, and the chance that they're going to just suddenly lurch towards emergency care or going to A&E or calling an ambulance. There's sort of things that tend to cost the system a lot, but they also cost the individual a lot as well. Because if they're getting to that red line where they're either so unwell they need it, or they think they're so unwell they're panicking and reaching for the kind of like the big red button, it's just not good. It's not good for anybody. So I love this concept of trying to kind of not it's not even a financial thing. It's a sort of like it's a better care system for everybody. And that's the thing that fills me with optimism. But we can start to move towards those style of financial models, and I think that the behavior, the way we work, will follow that.
Yeah, yeah. And so where do you think the kind of, the people, maybe some of the people we've been training, I suppose, where do they think they fit in? So we've got the link workers, I suppose I'm thinking about for the neighborhood teams and the health and wellbeing coaches.
Yeah, I mean, it's been really interesting, isn't it? Sort of like we know we can train someone in health coaching skills in 4 days. It doesn't take a lot because there's not a huge amount of background knowledge you need. It's more of a sort of mindset and a way of working, isn't it?
Mm.
But and similar with social prescribing link workers, we've seen how effective they can be, and care coordinators as well. When care coordinators are allowed to do the job properly, and they really are helping people to navigate a system. They're hugely beneficial, but the key thing is linking everyone together into a coordinated system. Yeah, what we see at the moment, isn't it, is that GPs are sort of like, in a lot of places, sort of just allowing that to happen. They're sort of going, okay, I can see coaching might be good for people with diabetes or chronic pain, but it's a bit of a kind of nice to have and an additional spend. And it's sort of taking money and resource away from people like me who are just seeing people in 10 to 15 minutes and churning through the demand. So they see it as a sort of antagonistic thing that they sometimes let happen because because they can see the benefit, but actually no one's really incentivizing them to work this way. So when things get tough as they have in the last couple of years, everybody wants to pull back. The opposite is if everyone's invested in this new way of working, then immediately someone like a health coach or a link worker is great value because they're helping people to navigate the system. They're encouraging them to look after themselves more, take more of a role, to connect more socially. We know those things are really effective if we're allowed to do them. And I think when I see GPs get really on board with this and they see their role as part of a big team together, they love it. It's great work when you're working with a team with a shared sense of purpose.
Yeah, yeah. And I know you're kind of a very much kind of a glass half full kind of person,
Oh, you
or,
reckon?
or maybe overflowing kind of person. So yeah. So you've taken a look at the 10-year plan, and you feeling optimistic, I suppose. Or there's
Yeah,
reason for
that is
optimism, I
sort of
suppose.
my brand, isn't it? I tend to try and be optimistic, if nothing else, because actually I think it feels nicer yourself if you're trying to look for the positives. We know that, don't we? Your brain tends to work better when you're looking for the positives. So I guess I've always tried to live like that. But obviously you don't want to be over optimistic, and that kind of sometimes opens you to sort of to naivety or to being hoodwinked sometimes, isn't it? Sometimes there's this sort of sense that the politicians are trying to just push us into a little box, whether we're patients or whether we're professionals, keep our heads down. So I think these sort of documents are great if we rise to the challenge. What I heard Andy Hilton from Primary Care Sheffield talk yesterday, who has been fantastic in Sheffield, leading a sort of quiet revolution in the background about how we join things together and manage to deliver things at scale. And what he's saying is that between the cracks of these words, there's opportunity. Primary Care Sheffield was one of the illustrations in the 10-year plan, actually, saying, look, what could happen if you start to sort of grasp the mantle. And that's what it relies on, doesn't it? Politicians can't tell you what to do. They can't write a blueprint for every way you work. They have to sort of lay out a framework and lay out an invitation, really. And then we have to take that challenge and make it work. and it will be different everywhere, but it will be dependent on the enthusiasm, the drive of the leaders and the people that follow them, and build that sense of team. So these documents are an invitation to me, and they live and die on whether or not we rise to the challenge they invite us to.
Okay, so we've got to rise to the challenge, but I suppose is there anything else that you'd want to see in terms of next step, I suppose, from the government? So they produce this kind of framework, maybe looking generously, they've offered us an invitation to kind of take up this mantle and do something. They take up the opportunity. Is there anything in terms of next steps,
Yeah.
you want to see from them?
Well, I'd love the government to operate like a coaching organization, really. Do you know what I mean? To ask us, so we've laid out our plans. What's your ideas? How do you think we could fulfill this? And what support can we give you to enable you to be as good as you can at achieving this? Rather than saying, right, here's your targets. If you don't hit this, then we're going to penalize you. Take a different view. Say, right, well, we've got this opportunity to put a year of care contract in. How would that need to look like for you? What would you like us to do? And give us a little bit of time. Give us anything new takes a couple of years to set up. So let's give you 3, 4, 5 years. Do you know what I mean? Let's tell us what you think you can achieve in the first couple of years, but also make sure that you tell us what we can hold you accountable to. That you've got to be held accountable to achieving stuff. You can't just pile in all blue sky and then not achieve anything. So what we know a good coach does, doesn't it? Is they're realistic about what's going on, what the reality is at the moment, what the capacity is, and what the capabilities are. They work with someone to look at what a better future could look like and what's realistic and what's attainable and what the time scale would need to be. And then they work with you to think about what are your ideas? How are you going to make it happen? And how do we support you? And how do we make sure that you're really specific about that? And you do have measures and you are reviewing them and you are accountable to them. But at the same time, if they've got resource that they can kind of either divert or wrap round us, then they make sure they do enable that and they give us the whether it's the air cover, whether it's the funding, whether it's the permission, they give us the things we need to achieve what we say we can do. That for me, that's the sort of relationship I'd like to have with the government, the NHS, whatever.
Great. Well, I hope they're listening. I hope they're listening.
Yeah,
That
we
would be
did
good.
a coaching style. That's the thing. We're a little bit biased, Tim, aren't we? Because we've seen
Yeah.
how fruitful that can be in so many settings.
Yes, we see the value. We absolutely see the value of that. But yes, wouldn't it be nice if we were on the receiving end of that as well? That would be good.
Well, the point is, I think we would rise. I think we would rise to the challenge. I look at all the CDs, the clinical directors of PCNs I know in Sheffield, and the leaders, like Andy, like the people that are leading the mental health transformation. There's some incredible, really dedicated, really thoughtful, very skillful people who are there. Sort of practice managers, and they just need to be trusted, but given the right environment. Seeds don't grow if you don't put them in fertile soil and water them and tender them. So we need tendering, but if we do that, we will blossom and we will deliver 100%.
Yeah, agree. And I think the other thing you need to do is create space around them. So again, maybe that space of some time to kind of for these things to develop would be really, really important rather than we need to see a return now or in 6 months or whatever. We know these things
Yeah.
take time, don't we?
They do, and sometimes people say we haven't got time, but that's a nonsense, isn't it? Because if we don't make time and it doesn't work, in 2 years' time, we'll be further down the line. They often talk about Derek Wanless, don't they, and his predictions in 2002, and he said if we don't develop a fully engaged population and a workforce that's really motivated and enthused, we will see a ballooning of costs. And actually, it's like Nostradamus almost. It has almost followed exactly what he said in terms of ballooning of costs. So you sort of think like, well, in 2002, they probably said, "Oh, we haven't got enough time to do this. We haven't got enough time," But here we are in 2025, and we've been taking that same attitude, and the costs have just ballooned. So at some point, we've got to just stop ourselves and go, "Look, it's going to take the time it's going to take." You can't rush the speed a tree grows. There are certain things that take time, but if you put those steps in place in a controlled and regular order, you will achieve the results in the end. That's for me. We've just got to be honest and realistic about that.
Yeah. And as we know, with trees, that we often talk about is actually paying attention to the roots which is the bit that you don't see. You don't get to see,
Mm.
don't get to see anything. But if you don't pay attention to the roots, you don't get the good fruits down the line. But it
Yeah,
is often down the line that you get those. It's not in 6 months.
I love that, mate.
It's
So what are the roots here then, Tim? What do you think? What do you think are the key roots then to blossoming NHS? Let me throw that back to you.
Well, I suppose it is. It's building, it is built. Well, again, when we talk about it with individuals, and I suppose we could maybe think a little bit about as the system as well. Can we build the confidence and the knowledge and the skills of the system, I suppose, to develop. And
Yeah,
again, sometimes what happens is we make kind of short-term changes and we lose some really great people with lots of wisdom. And we also don't make the best use of the wisdom in the communities that we have as well. And again, it's tapping into those resources, which I think we're missing. What do
yeah.
you think?
No, I think it. Yeah, there's so many parallels, aren't there, with the sort of concept of patient activation. There is maybe a kind of concept of system activation, isn't there? And it just feels like we, I don't want to be too political, but like, the this government who, I believe in their sort of politics. I really want to support them, but we want them to be really clever about this, don't we? If they don't do it well, it bites them in the foot. They've had to do lots of U-turns. They've had to go back on things. It's like, come on, maybe we can inform you a little bit better, and this can be a little bit more intelligent. And it's really hard, isn't it? Because it's, the politics at the moment is very popularist, isn't it? Very short term. And so actually allowing even a politician to be long term and, as strategic as you want them to be is sometimes not a luxury they have. But I don't know, maybe we can give a bit more confidence around that and make sure we're on their side anyway. At least we can do that.
Yeah. Great. Lovely, Ollie. I'm conscious of time. Is there anything more you
Yes.
want to add before we
No,
kind of...
gosh, sorry, I've done a lot of talking today, haven't I? But
That's all right. I'll have my turn down the line, I'm sure.
you will, you will. Well, it's lovely chatting with you, Tim, and I hope we do. Oh, it'd be really, really nice to hear people's views. I don't know if what we're saying resonates with people, if it gets people. The whole idea of this, isn't it, is to spark thinking in people and to spark thoughts and reflections, and maybe to build this sort of energy and kind of like sort of momentum around a coaching approach to the NHS, to life, to the way people practice. It's something we really believe in, and we would really value your thoughts on how we can build this together.
Yeah. Nice one. Okay.
Thanks, Tim.
All
Brilliant.
right. See you
Cheers.
soon.